We're visiting today with Khadija Shahid. She's a board-certified optometrist with her training at Salus University in Pennsylvania and a residency at the College of New York. She's published many times and has presented, lectured on telemedicine and screening of diabetic retinopathy, and I think you'll enjoy her presentation today. After, we'll ask a few questions if it's okay.
That's awesome.
Hi, this is Dr. Shahid. I'm from the University of Iowa, Assistant Professor of Ophthalmology. I wanted to talk to you today about diabetic retinopathy. It's become one of the leading causes of vision loss in the world and in the United States, but it is a preventable disease. And so I want to talk to you. I'm working in collaboration with the Iowa SIM project, and what I'm hoping to do today is go through diabetes itself, the public health burden that we face because of this disease, specifically the populations that are affected, and even with our own backyard in the state of Iowa. And then my interest, diabetic retinopathy, or the ocular disease, the eye disease associated with diabetes. So I want to show you what that looks like through case presentations and talk about preventing this disease, what our role is, and in supporting people who have this disease. So we know that the disease, diabetes, is increasing throughout the world. What's interesting though, back in 1980, less than 5% of the world's population, adult population, had diabetes. As of 2014, that number's almost doubled. And what we see, if we look at the global map of diabetes, is the increase is happening throughout the world, but more largely in those developing nations. If we look at the continent of Africa, Asia, South America here. And so what that tells us is this is more than just a physical disease, but a socioeconomic condition associated with income status, with social conditions. Back in 2000, the predictions over the next 10 years was that diabetes was going to increase by almost 50%, that the number of adults affected with diabetes would be over 220 million. And we've surpassed that. According to the International Diabetes Federation, in 2011, over 360 million people have diabetes, and those numbers are going to continue to increase. And again, look globally at those developing nations, a 90% increase in the prevalence of diabetes in the continent of Africa, Asia, the Middle East, South America, those developing nations, those lower income countries. Within the U.S., close to 10% of our adults have diabetes. What we see again are socioeconomic specifications that the prevalence tends to be higher as we age and in certain minority groups. In fact, if we look at Native Americans in the United States, nearly 16% of adults have diabetes, more than any other racial group within the country. In certain populations, the Pima Native population of Arizona, up to 80% of adults have diabetes. That's amazing to consider that, especially if you compare the same Pima Native population in the country of Mexico, where they're not living on a reservation, where they don't face with the same socioeconomic disparities. You don't see nearly the same prevalence of diabetes. That's within the same group in two different settings. If we look at Black and Hispanics in the nation, they definitely have a higher risk of developing diabetes compared to their white counterparts. Average about 13% of adults. That's higher than the national average. Within our own backyard, diabetes is one of the 10 leading causes of death. And it's estimated that as many as 40% of those adults that live in Iowa have either diabetes or prediabetes. So that's almost half of our Iowan population. Again, the higher prevalence as you get older and in certain minority populations. But look at the other risk factors. Having a lower income increases the risk of developing diabetes, your educational status, your physical attributes. And the predictions, according to a report released in 2011 for diabetes and chronic diseases in Iowa, if things don't change, then at 1 in every 3 persons born in the year 2000 have a risk of developing diabetes over their lifetime. Consider the impact on the person, on our state, on our nation, and our population. If we consider risk factors for diabetes, we know that being overweight is a huge risk factor. The majority of the people in the world and in our country have diabetes, have type 2 diabetes, and that is largely associated with health status. And more than 80% of the people who have type 2 diabetes are overweight or obese. The concern is we continue to age, we're living longer, which is a good thing. We're seeing diseases we didn't see, and we have to deal with that, but our lifestyle is changing. If you look at modes of transportation for your family in rural villages of China, compared to urban, developed areas of China. So we're leading more quiet, less movement lifestyles, and our nutrition. This young gentleman is sitting on a truck full of soda, the amount of sugar and carbohydrates that we ingest, so that we see the obesity and overweight rates increasing not just in adults, but in children. And alongside that obesity epidemic, parallel is this epidemic of diabetes. Most alarming is the change in our children. Looking at overweight and obese children throughout the world, the Americas, North and South America, are winning this race that we maybe aren't so proud of. Looking at overweight children and obese children, compared to the world, the Americas have the largest number of children that are overweight and obese. The U.S. leads the nation in overweight and obese children. So we are diagnosing type 2 diabetes, largely associated with overweight in children as young as 8. In a recent report, a 3-year-old child was diagnosed with type 2 diabetes, put on medication, drastic lifestyle and nutritional changes, weight loss, and within a few years was able to control the disease and get off medication. But a child that's 3 to 8 years old that develops a chronic disease, you see them several years later, and now we have children in their teenage years with cardiovascular damage secondary to diabetes. What is a lifetime of this disease going to do to that many children in our country? Diabetic retinopathy. So when you have a devastating disease like diabetes, you have to deal with a myriad of complications. Diabetic retinopathy is a disease that affects the eye, the more common diabetic complication. Probably 1 out of every 3 individuals who has diabetes has some form of retinopathy. What's difficult is that untreated, unchecked, this disease causes vision loss, permanent, and in some cases total blindness. And so within the world, it's estimated that over 800,000 people are blind from a preventable disease like diabetic retinopathy. Within the United States, 1 in 3 have some form of it, and again, because the numbers of diabetes are expected to increase, so are the numbers affected with diabetic retinopathy. Diabetic retinopathy is one of the number 1 causes of vision loss in the world. The World Health Organization estimates that over 200 million people are visually impaired or blind, largely from preventable diseases, including those related to diabetes or diabetic retinopathy, largely in developing nations. Again, a socioeconomic condition that can be prevented. 80% of the people that are living with vision loss could have been prevented or could be cured with the right access to care. So how do we prevent diabetic retinopathy? There's 3 major factors that predict the development and progression of diabetic retinopathy. The first being duration of the disease. So again, consider our children. If we're getting this disease at a much younger age, that's a longer time where it has the risk of causing complications like vision loss and blindness. It's related to levels of blood sugar. So hyperglycemia, high blood glucose levels over several years increases the risk of diabetic retinopathy, and increased levels of blood pressure. Hypertension over several years increases the risk of diabetic retinopathy. So what do we tell our patients over and over? What do healthcare workers need to reinforce over and over? Patients with diabetes need to control blood glucose and blood pressure. And the more these numbers are controlled, better control means better outcomes. To not only decrease the risk of ever developing the disease, but should you develop it, decrease the risk of losing vision from that disease. In fact, this is so well known, so well published over and over in the literature, that the government has set standards. The Healthy People 2020 initiative, it sets 20 national goals to improve the health of America related to diabetes alone, including specifically patients with diabetes and the goal of improving blood glucose, blood pressure, and cholesterol levels. How else do we prevent diabetic retinopathy? We need to be able to detect it. So when we talk about the anatomy of the eye and how diabetes can affect the eye, it actually can affect nearly every part of the eye, from the front focusing lens to the internal structures to the nerve, the optic nerve that transmits information back to the brain. But we can image an eye, and we can view part of the retina, that specific part. It's most likely to show early signs of diabetic retinopathy. We do the same thing in the office when we dilate a patient's pupil and we can view the retina, the entire retina, and not just a limited part. What we're looking at here is an image, a 45-degree image. So we're looking at, through the pupil to the back of the eye, this area of the retina, probably about this large, about 45 degrees. And here you can see the face of the optic nerve and the retinal vessels, retinal veins, retinal arteries that enter the eye through the optic nerve and continue along the surface of the retina. These are the most vulnerable parts of the eye to diabetic retinopathy. The early signs that we can visibly see are going to be along blood vessels on the retina or affecting this tiny central part of the eye known as the macula, where your 20/20 vision is. So an example of a healthy eye, an image of a young girl with type 1 diabetes with a healthy optic nerve, good blood vessels, and no diabetic retinopathy changes. We compare that to an unhealthy eye. What we're looking at here is a blow-up of a capillary and a blood vessel wall that's so scarred up, fibrosed, and weak that the walls actually burst and these tiny little red blood cells are leaking out. So higher levels of blood glucose in the system weakens capillary walls. High blood pressure pushes through those walls and causes diabetic retinopathy or retinal hemorrhages that we can see after years and years of high blood glucose and blood pressure levels. And so the early stages of diabetic retinopathy, we're looking at an image here. Non-proliferative diabetic retinopathy, which we further categorize based on how severe it is. Usually patients that have early changes, and if you look closely you can see along the blood vessel walls are tiny spots of retinal hemorrhages here. In fact, if you look really closely, it's pretty much throughout the entire posterior pole and close to the macular area. Despite all these little spots of blood in the eye, the patient's completely asymptomatic in this case. Vision was fine. Usually, in these stages, the disease is reversible, and it's reversible simply by getting blood glucose levels in check and blood pressure levels in check. Non-proliferative, severe levels advance and become what we call proliferative diabetic retinopathy. When we talk about proliferative, it's the proliferation of new blood vessels. So remember, because of all the high blood sugar in the blood vessels, we're not getting enough oxygen to the eyes. And the blood vessel walls are weak. They're weak, we have leakage. Because we don't have enough oxygen, the body is really good at trying to heal itself. So it forms these new blood vessels. If you look really closely, you see these really thin, wiry blood vessels on the optic nerve, next to the optic nerve. And you can see the difference between new blood vessels versus the older, larger, more straight blood vessels. These new blood vessels are trying to get oxygen to areas of the retina that are starved of oxygen. The problem is they're tiny, they're fragile, they're weak, they break, and they scar. This stage of advanced diabetic retinopathy, unchecked, can continue to cause massive problems. By the time this patient presented to us, their entire eye was filled with blood. This doesn't happen overnight. This is years and years of high blood sugar and blood pressure, and nobody examining the eye. You can barely see the optic nerve. What you do see is an eye full of blood, scar tissue, probably new blood vessels that tried to form, that broke and bled and formed tissue, older blood throughout the eye. And similarly in this patient, an eye full of blood. This is not reversible. In most cases, this requires ophthalmic intervention and treatment. This generally leads to vision loss, maybe not permanent, if you can catch the patient early enough and still save some vision and some of the eye. Advanced diabetic retinopathy. One other category of diabetic retinopathy that you might hear is diabetic macular edema, and that has to do with changes in the center of the eye and that tiny little macular area. Those tend to be symptomatic, meaning patients notice vision changes, because this is where your 20/20 vision is. So in this patient's case, you see a lot of changes happening outside, hemorrhages, little fatty components that leak out of the blood, little areas that are white and opaque because it's starved of oxygen, but changes in the center here that are affecting the patient's vision. This requires treatment. This doesn't go away on its own, so we need ophthalmic intervention and ophthalmic specialty treatment. The problem, and why diabetic retinopathy is such a big problem and continues to remain a large problem, is recognizing the disease. Not every patient who's diagnosed with diabetes realizes that I need to get my eyes checked, not just once, but routinely, every year, maybe more. And not all of our community healthcare providers are aware of the need to refer patients for ocular screenings. When a patient's diagnosed with diabetes, there's multiple factors that come into play and multiple things that need to be addressed. And an eye exam may not be on the priority list. Not to mention the disparities that different clients of ours have to deal with. Do they have access to health care? Do they have insurance? How's their income status, their work status? Can they take time off to get an eye exam? So for the last part, I just want to go through a couple cases of patients that have presented to us over the years with diabetic retinopathy and their specific scenarios. This was a 50-year-old male who was referred to us from his primary care provider because the doctor recognized this patient had had diabetes for 10 years, and he couldn't recall the last time he had his eyes examined. He had no visual complaints. But remember the factors involved with the progression and the development of diabetic retinopathy, duration of disease. He's had type 2 diabetes for 10 years. That's a risk factor for developing retinopathy. His A1C, so this is average blood glucose levels, generally that's about a 3-month average, was 6.2. So generally in patients with diabetes, we like to see A1C levels lower than 7. Every primary care provider is going to have a different goal for every patient based on their history. His wasn't too bad. What was concerning was his blood pressure, that he's been on medication for 5 years, and his health status. His body mass index was very obese. We dilated his eyes and looked at the back. We're looking at the right eye here, and you can see 10 years of diabetes, and he has diabetic retinopathy. You can see changes all along the blood vessels. He also had changes related to his uncontrolled blood pressure. He had no visual complaints. Left eye looks worse than the right eye. Look at the bleeding along the retina. Again, no visual complaints, despite the grade 2 and 3 retinopathy he had in both eyes. This patient read 2015 on the acuity chart. That's better than average. His A1C, or his average blood glucose levels, weren't too bad. What was bad was probably years of uncontrolled blood pressure and his body mass index. So if we were to compare his eye to a healthy eye, on the left is a healthy patient, no diabetes. On the right, patient with diabetes and diabetic retinopathy. Both of these patients have better than 20/20 vision. The difference here is if the guy on the left never had his eyes examined, most likely it would never be a problem. The guy on the right, if he hadn't come in, would most likely lose vision over the next several years, not to mention the risk of walking around with uncontrolled blood pressure and the cardiovascular risk stamps. We talk to our patients over and over about managing their disease, all the levels, about getting routine screening. These are what we can do to prevent diabetic retinopathy. Once it's there and once it's at an advanced stage, we need to get our patients to specialty care for interventions and treatments that could include laser photocoagulation or cauterizing blood vessels in the back of the eye, injecting medication in the eye. So yeah, we're talking to our patient about getting a needle in the eye, or surgery if it's bad enough. I want to talk to you about a 19-year-old male who's had type 1 diabetes for 15 years. He was 4 years old when he was diagnosed. When he presented to us for retinal screening, his A1C was 12. That's terribly high, terribly uncontrolled blood glucose levels. Blood pressure was slightly high too. When we imaged the back of the eye, he had no diabetic retinopathy. This was 2013. Because of the high blood glucose levels, we wanted to monitor him closely. He didn't come back for 2 years. 2 years later, he's 21 now. His A1C is off the chart. We can't even measure it with our screening method. His blood pressure is even higher. The only reason he came back 2 years later is because now he noticed his vision's not quite as sharp as it used to be. And imagine what the back of his eye looks like at this point. It's hard to see, but if you look really closely, there is hundreds and hundreds of tiny spots of blood throughout the entire back of his eye. He has severe non-proliferative diabetic retinopathy. So in 2 years, he went from pristine to terrible retinopathy. His A1C went from bad to worse. So you can bet he came back 2 months later like we asked him to. And at this point, he was working hard to get his blood sugar down, to get his blood pressure down, and noticed that his vision had improved. And within 2 months, we saw a change. So if we could look at that side by side. 2 months later, there's a lot less hemorrhages or spots of blood in the back of the eye. Blood sugars improved, blood pressures improved. What did we do for this guy? Nothing. No medical intervention. What we did is we talked to him about his health status. We got him involved, and somehow we got him to be motivated and to become actively involved in his healthcare. We recruited his family for help. And what we find over time and time is that patient and family involvement in healthcare is crucial to the health and to the better outcomes of those patients. So we don't have those days where we're telling our patients what to do and they blindly follow our orders. We're asking patients to manage, we're asking families to manage actively, get involved in their healthcare, and they do a better job than we as physicians can do. This last case is a young female who had just been diagnosed with diabetes about 2 months ago and high blood pressure. Health status wasn't the best. Look at her blood pressure, extremely high, and her blood sugar, very high. She came for an eye exam because she'd noticed problems with vision, especially her right eye. She had severely decreased vision. That's 20 times worse than normal. When we looked at the back of the eye, what we see is diabetic retinopathy, what we call hypertensive retinopathy, and macular edema. So explaining why her vision is decreased in the right eye. And then the left eye, it doesn't look much better, but because it's not affecting the macula, she didn't notice. This is someone who needs specialty ophthalmic intervention and treatment, but this is someone that we need to have a conversation with. This is engagement from community healthcare workers, from physicians, talking to the patient about maintaining their disease. So most likely she's had diabetes and high blood pressure for years. This patient had no health insurance, no access to health care, and no access to treatment until about 2 months ago when she presented to the hospital and was diagnosed. We talked to our patients about the bad, high blood glucose, high blood pressure, smoking, and about the good, what they need to do. Monitor their nutrition, their disease levels, stay healthy, stay happy, and come in for routine eye exams, not just once, but as instructed. Because patients who simply came to the eye doctor when they were supposed to, and even if they changed nothing else, improve the outcomes of their visual acuity for longer than those who didn't follow up with eye care. So tell your patient in the very least, or tell your clients in the very least, go to the eye doctor, and that alone is enough to preserve your vision longer than if you didn't. The problem with patients with diabetes is it's such a complex disease. It affects so many aspects of their life, and they can have visual fluctuations that may not necessarily be related to diabetic retinopathy. Simply, large changes in blood glucose levels will affect the vision, and it affects their ability to manage the disease. There's a lot of anxiety associated with diabetes, a lot of distress, a lot of self-blame, but we know it's not just always the patient's fault. It's a socioeconomic condition. It has physical, it has mental morbidities. It can cause disability, it can cause vision loss, it can cause your clients or patients' inability to be able to manage their day-to-day activities, which includes going to work, maintaining health insurance, driving to their eye doctor's appointment. It can cause depression. Patients who have diabetes are twice as likely to develop depression, and patients with diabetes who are depressed are more likely to have higher levels of blood glucose, more likely to develop diabetic retinopathy, and more likely to die from complications of diabetes. So consider the fact that a patient that has diabetes who's depressed has a higher risk of death than their same colleague who has diabetes who's not depressed. So by recognizing this, we can help prevent and improve quality of life, not to mention life itself, for a lot of these patients. So I'll leave you with this last graphic that kind of illustrates screening for diabetic retinopathy. Any of your patients or clients who are diagnosed with diabetes needs to have a baseline eye exam within the first year of their diagnosis. And that eye exam can be done by a local optometrist or an optometric physician or a local ophthalmologist. If the screening is normal, the recommendation is to have an annual eye exam with a dilation by, again, local optometrist or ophthalmologist. Any abnormal findings, we need to engage the patient in what's happening and what they can do to limit the disease. We need to either repeat the test or refer patients for specialty care.
Thanks, Dr. Shahid. Just a few questions. How soon after a diabetic diagnosis should a patient schedule their eye exam?
That's an awesome question. So the recommendation is once they've been diagnosed, within the first year, they need to have a baseline eye exam with an optometrist or an ophthalmologist. So our recommendation is within the first year, we'll get in, we'll do the eye exam, and then if everything's within normal limits, we want to see them at least every year after that.
Great. In addition to diet, exercise, and regular checkups, is there anything a patient can do to prevent diabetic retinopathy?
Yeah, basically, very fundamentally, I tell my patients be happy and be healthy. Mental health is just as important as physical health to keeping diabetic patients healthy. But specifically, at least for the eyes, we say keep that blood sugar stable. That's probably the most important factor to prevent the development of diabetic retinopathy or to prevent it from getting worse or even once you develop the early signs to make it go away. Second to that is your blood pressure. You want to keep that strictly under control with your doctor. Lipids, cholesterol control makes a difference. We talk about nutrition a lot, eating more vegetables and less meats, less sugars, and working hand in hand with the nutritionist really helps because most of us know what to do to stay healthy, but actually doing it is challenging. And when you have somebody counseling you one-on-one, that makes a big difference when you have to report to somebody and write down what you're doing. So those are some basic things we talk about during the eye exam.
Wonderful. Where can patients and providers find more information about diabetic retinopathy?
The best place is your eye doctor, and that's actually what most people want. They want information from the person who's reviewing them, their regular doctor as well. But we like to go home, we like to Google, and it's hard to sift through all that information. So asking your provider a good website. We always recommend National Institute of Health. That is peer-reviewed, meaning educated people, research, publications are constantly updated on that site. Specifically for the eyes, the National Eye Institute is a good one, the American Diabetic Association. Those are some really reputable websites that you can go to.
Great. Are there ways that community service groups can help promote diabetic retinopathy awareness and better health?
Absolutely. Talking about it, getting the information out there, doing what the IHC and the SIM communities are doing, talking to patients and community workers, directing them to the right websites, the right references, setting up educational meetings like they are. All these things, these community efforts make a huge difference.
Excellent. Thanks very much.
Awesome. Thank you.